So hi everyone, thank you so much for joining us tonight. So this is part of Can We Talk series, where we have open and honest conversations around fertility. So today's topic is you've done everything but still no baby. So for many women, this is where things start to feel really confusing and really exhausting, especially if you've waited, you've tried, and even gone through treatment, but you don't know what to do next. So today we have Dr. Jessie Phoon from Gen Prime and STOG, who will help us understand both the medical side and what might be happening and what you can do next. So with that, let me invite Dr. Jessie in and we can start today's talk. Hi, Dr. Jessie.
Hi, Kim. Good evening.
Hi.
How are you?
Good, thank you. So thanks, Dr. Jessie, for joining. And maybe we could start off with you introducing yourself first, and then we can go from there.
Sure. I am Dr. Jessie Phoon. I'm an obstetrician gynecologist by nature, and I subspecialize in IVF, or in general terms, we call it reproductive medicine. So I'm qualified in the whole field of what we call assisted reproductive technique. I had a special interest or passion in fertility preservation, especially that was my so-called fellowship. But in general, because we are in a small little country, we actually see everything about the world of reproductive medicine, essentially. Yeah.
Yep. I think Dr. Jessie is someone who really knows a lot, and so I'm very happy to be doing this topic with you today. And I think that you can answer so many questions. So if you've got any questions, please type them out as well, and we'll try to ask as many as possible. Okay. So today we're talking about obviously the topic of you've done everything but still no baby, right? Is this something you hear quite a lot from your patients that come to see you?
Unfortunately, yes, I do from time to time. Thankfully, it's not an everyday question. Otherwise, my life will be very difficult. But yes, it does happen to a certain profile of patients because there's just so much we can do, whether it's the patient or me as a doctor.
Yeah, and I think we hear that quite a lot in our community as well. So when these patients come to you, basically, I mean, what have they already tried? And is there anything that would have missed out at that point in time?
So I do see a spectrum. There are some who comes very early. And usually those are the easier to tackle, as they're starting out, I can guide them along from the very beginning. But of course, I get the extreme ends where they are obviously coming after many, many treatments or midpoint, in fact. Being in a small community in Singapore, we are quite small. So I do get quite a lot of what we call second opinions. Yes. And I don't see any harm to second opinions. It's always good to get fresh opinions, put it that way.
Yeah. I totally agree. I think that, sometimes, especially, for us, I think it's not that you shouldn't follow one doctor all the way, but I always think a second opinion is good because you may find out things that you kind of never know before. Yeah. Yes. So, but when a patient comes to you, right? I mean, is there anything that you often see, oh, this has been overlooked, or, you've done these tests, but you haven't done these tests, or, what usually do they come to you and you find out?
Yes, very often certain little things are missed because as it is actually reproductive history taking is a very big portion of our so-called consult. I would say my first timers get about 45 minutes with me, and that itself, I may not be able to complete the history itself. Don't talk about physical examination and what to offer you, right?
Yeah.
So there are times that all of us are perfect. We may miss certain questions about, say, your lifestyle, your holistic care. Are you, actually healthy to conceive in the first place? Did you do the so-called compulsory, necessary investigations, or are you assuming you are fine, Or are you understanding your basic menstrual cycle? For example, you know when to even try or not try, what is the timeline? So yes, on and off, I do feel that there are people who are still missing things that they are not, discovering on their own. And that's where, I come in to help. Hopefully, we call it holistic care, to embark on this journey together as, a whole, or rather a package.
Yeah. So for the patients that usually, come to you that are either mid-treatments or, second opinion, do you find that a lot of times they come to you not knowing their full history, or not recording or they should have recorded a lot of things, but they didn't, and they come to you like, oh, I didn't know, I don't know what the information I should give you kind of thing?
Yes, I I do find that on and off. I won't say it's a very big population. Nowadays, the good thing is our younger population are a bit more educated. So awareness has been great, I must say. So a lot of them do understand what is general fertility or, how to conceive, but they do miss out certain fine prints that maybe, I'm just there to guide them discover at times and to add on certain things that, we can probably improve to a certain degree. I won't say, a market improvement, but anything better than nothing.
Yeah.
And a lot of the second opinions, especially when they fail cycles, honestly, it's about time, about talking to them. That it's probably just not your time. You just need to take a bit of time, have a little bit of patience, be a little bit less anxious, and ultimately it will come eventually. Especially if you have a whole load of embryos banked, right? So
Yeah.
don't be too surprised if I failed two transfers. Actually, two transfers in the realm of say 10 embryos or 10 blastocysts, it may not mean very much actually.
Yeah.
So you just need a bit of time sometimes. So patience is something that I do emphasize. Yeah.
But patience is not something that we have, on this journey, unfortunately.
So
One
it
of the
depends on
worst things.
age and timeline. It's true.
Exactly. We want the baby now. That's the thing. That's the problem.
Yes.
So, we have a lot of ladies that often, they do all the tests that's necessary to be done. And then the doctor says, hey, your tests are normal. There's nothing wrong with you. And it's so frustrating and everything. But, but they're still not getting pregnant. So usually when they come to you, right, and saying that, hey, everything is normal, what should I do next? What do you usually advise them?
So this is very real because in our medical school or rather in fertility, 20% of couples fall into this category. It's about 20%, 1 in 5 couples, okay, quite big. We call this unexplained infertility.
I hate that word.
Yes, I know. In Chinese, it's worse. All my Chinese patients will come to me, 没有原因. What does it mean by 没有原因? Or, 解释不到. But literally from English, it's called unexplained, right? That's why we are just literally, translating that to you. But I don't believe it's unexplained. It's just that it's not explained in all the obvious factors that we know of the reproductive anatomy.
Yes.
So the obvious things that we can see and, obvious reasons that you won't get pregnant if these things are not present or if there's something blocking. So there are a lot more that we don't know about our body. Okay, whether it's molecular, pharmacokinetics, your genetics, for example.
Yes.
So that is that unfortunate term that we have to, label you. I also personally don't like it.
Yeah.
But along the way, whether we can help you explore and, find you a reason is a very, very so-called, subspecialty in a small little group. Ultimately, a lot of times, even when you succeed, I cannot tell you why you suddenly succeeded, on the other end. But it's a very real question. Fortunately, actually, if you are young enough with the good parameters of, say, still presence of eggs, still presence of sperm, a big group of so-called unexplained infertility still will be pregnant at some point.
Sooner or later, right? Sooner
or later. So, but it does take a bit of time for certain profile.
Yeah. So, but at any particular point in time, do you say, hey, looking at this, okay, seems normal, but are there any tests? Because we always get asked this, hey, any test I can do, or anything my husband can do, but is there anything that they can?
So first and foremost, I actually emphasize on basic health. You must be healthy to conceive or rather carry a child in the first place. So for the female, it's important to, eat healthy, sleep healthy, reduce stress. I know it's very easy to talk about this, but I will elaborate this a bit later. Obtain what we call or achieve a healthy BMI. I always encourage what we call regular exercise. It's not about losing weight. It's about just hormonal regulation.
Yeah.
So you'll be surprised just with exercise, it creates endorphins. You'll be happier, you feel happier, you sleep better, quality of sleep, you have sex more. Ultimately, it's a vicious cycle, right? And then we tell you, okay, you are fit now, you are ready. So no medical problems, very important. I routinely screen for thyroid disorders, diabetes. Yeah. Of course, you want to know your full blood count or rather your hemoglobin. Make sure you're not anemic when you're conceiving. Otherwise, you will just end up miscarrying or high risks in pregnancy. So those are quite basic profile. You must understand your natural menses. Are you even ovulating? So a lot of
Yep.
patients don't understand what is ovulation. Actually, when I ask them, yeah, it's like I will ask, do you get this discharge? Do you check your ovulation? They look at me blindly.
You mean I don't get pregnant every day of the month?
Exactly, something like that. So if they're not having sex at the correct timing, it doesn't work either.
Yes.
And of course, sexual dysfunction is very important.
Mm.
And for the males, a lot of them think that their role is very small, but actually they play a very big part. Yeah, I mean, apart from just producing sperm and having
Yeah.
sex, they
Yep.
have to be healthy to give rise to good sperms. You see,
Yes.
they may not realize that if they are just working, no good sleep, no good health, sperm production may be low, and you may get very poor quality sperms.
Yeah.
And of course, if you have so-called some form of oxidative process going on, especially things like smoking, binge alcohol, all this will impact your sperm quality. So this is when, I will advise, please go and help improve yourself, take some multivites or supplements, some form of antioxidants. If you can cut smoking, that's the best, because there's no such thing as healthy smoking. But it's difficult. I mean, I won't say you have to cut to zero, but any effort actually contributory to success. Put it that way.
Yeah. I mean, I think these are points that sometimes people say, hey, but all the doctors say the same, but it makes sense. It has to, you need to get over that first before, you kind of will be able to get pregnant. That's the thing.
And in our Singapore population, I feel the biggest stressor as a basic thing is we are not having enough sex. We are always working.
No time, no
Yes,
energy.
no time. We work 12 hours a day. By the time you come back, you have a dinner, you just want to lie in bed or watch TV, watch your IG, scroll doom, just scroll doom half an hour and then, it's time for bed. So it is a very easy excuse, I must say. But if you can make the effort to spend a little bit of time or take time off, I do tell them, why don't you take some holiday, time your fertile window and just go somewhere.
Yeah.
It doesn't matter, it can be just 2-3 days, but at least go and, relax.
Yeah.
I do have very high strung occupation sort of patients that probably need to take sabbatical, like they take 2 months off, 3 months off, just to embark on a journey. That is real effort, I must say. Yeah.
It is. But okay, for those who are maybe newcomers today, so what is enough sex? Okay, because some people, do I do it 2 times a month or whatever? But maybe let's educate them for those who are new.
Yeah, so there's no such thing as too much sex, honestly. So leisure sex is always welcome in our world.
Okay.
But most importantly is that if the female identify the fertile window, usually it's 2 weeks prior to the expected menses, there is a window of about 1 week. And during that 1 week fertility window, you should have sex every 2 to 3 days. And this is purely because sperm hangs around in the system for almost 72 hours, but the egg is only swimming or around for 24 hours. So you want constant sperm to catch the egg whenever it releases. Yeah.
The more sperm that goes in,
minimum.
the better lah.
Yes, definitely. Yeah.
Got it. So you see, it's tiring, but I mean, it's
necessary.
It's necessary. It's really necessary. But I mean, try to make it a bit more romantic. I remember when I had to do it and everything, it got to a stage where my husband was like, huh? Again? It was just, it's hard for the woman, but it's also hard for the man. But I think, yeah, unfortunately, we have to do it if you want a child. For those who have already gone through, let's say, okay, let's talk about IUI first. Okay, so I think the person has gone through IUI. How many IUIs? And the doctor says, okay, let's go. You failed the first round. Let's do another round. How many rounds of IUI do you feel is necessary before they should go to the next step?
So you are talking of obviously an optimal cycle IUI. Means you must achieve the optimal number of eggs that you targeted for, and the sperm concentration must be of a good post-wash or rather post-processing sperm recovery. So if all these targets are met and they are generally a young couple, means we are talking about a female couple of say less than 40 years, we truly believe if time permits, minimum 2 to 3 cycles.
Okay.
So, and I'm talking about super ovulation, meaning multiple follicles for somebody who has been trying on their own. If they've never tried, never had sex, then it's a different story. All you need is probably just 1 egg a month. But in general, for this profile who has not been succeeding naturally, you want to improve the odds. So you are talking about super ovulation IUI. Means try to generate at least 2 to 3 follicles for better success, especially if you are older, to compensate for the chromosomal abnormality. Now, in saying that most consensus or guidelines advise minimum 3 cycles. In the older guideline, they even mention 6 cycles. The problem with IUI is time taken.
Yeah.
So most patients, when I advise you 2 to 3 rounds or cycles, I expect only a downtime of 2 to 3 months. But most patients in our context will always take a break for whatever reason. They feel they need to recover or do something different in that subsequent month. And then, okay, I'm not succeeding, let's start the next round. So by the time the next round, the second cycle, it may be 3 months later. And if you are going to delay this, 3 monthly process, then it becomes almost a 6 to 9 months journey. Then it's not worth the amount of cycles already. If you are that kind, then I rather, start you early in your IVF journey if you are of a certain age group.
Okay.
And personally, my threshold for so-called, if your egg counts are good, provided 37, 38 is when I notice a drastic drop. So we like to use 35. 35 is because 50% of our eggs are already quite useless in chromosome disorders. But 37, 38 is when you drastically drop in quality and numbers. So that is the age group that I would be wary. If you are keen to do IVF, you rather start early than too late.
Got it. So, and we were also talking not normal IUI, but super ovulation where you do the injections.
Yes.
And then, do you see a lot more people doing super ovulation? Because we always hear of more people doing normal IUI. We don't really hear so many of the doing SO IUI.
Actually nowadays the younger generation actually advocates super IUI because the older generation is, if you assume that you are not having enough sex, then natural IUI makes sense because you want to keep it as cheap as possible, right? But a natural IUI relying only on 1 egg a month, actually in general across all age, your success rate is at best 8%. So that's less than 10%.
And what is natural conception? The percentage of natural conception?
Okay, if you are fertile, every month you are trying properly, then it's almost 15 to 20%. Yeah, so this 8% is just an additional benefit, the fact that you cannot get pregnant now. So it's not much higher actually. But super ovulation in women less than 40 years, you can achieve up to 15 or 18%. So that's double of your 8%.
Yeah.
So we think that if you can double your odds with a little bit of low dose stimulation, whether it's by ovulation induction pills or low dose injections, we think that it's more worth it. Because ultimately, if you have normal anatomy, we do have 2 tubes. If you can grow eggs on both sides, you actually can potentially double your odds. But it's true that IUI does confer a risk of multiple pregnancies because that is one thing we cannot control, the number of babies. Once we shoot the sperm in, you can potentially get more than 1 if you have more than 1 egg.
Yeah. Okay, but do you see that happening very often or not?
No. Honestly speaking, no. So I quote a general success rate of 15 to 18%. Only 5, at most 10% of that group will get multiple. So majority, 95% will still get a singleton healthy baby, honestly speaking.
Got it. So see, there's certain things that, they tell you about, we don't have to worry too much. So yeah. How about IVF? Now when we touch on IVF, so tried IVF, everything seems normal, but doesn't work. What's next?
Okay, so it's very, very dependent on female age, unfortunately. Because when you come to IVF, yes, we help you potentially create the baby, right? The embryo. But we still rely on good quality eggs, good number of eggs, good quality sperm, good number of sperms. So sperms in general, they come in millions. So hence it's never a problem to match the number of eggs because it's hard to get millions of eggs per cycle, right?
Yeah.
So an average cycle, if you are what we call a normal responder, means good, healthy, I would say a median age of 35, you should easily give me, say, 15 eggs. Then I only need 15 sperms. Put it that way, right?
Yes.
So and then you go by the percentage of normality. Only 50% of these eggs will be normal chromosomically. But at every stage, there may be drop off due to either fertilization process or what we call growth, because issues come at various factors. But why do I say age is most important? Because the success will be dependent on a younger egg to help what we call embryo development. Good development of embryo. So I just wanted to delve a little bit. I know later we're going to talk a bit about sperm, but sperm roll is important. It's just that the eggs roll being the larger component is way bigger than a sperm, by the way. It is the powerhouse of an embryo. It's a generator set, put it that way. If you think about a gen set, that is the power engine. If you don't have an engine, nothing works, nothing will grow on. So that's why eggs are more precious. That's why females are more precious. Because we have a finite number and yet we are the power generator. If you don't have a good young egg, your power generator engine is of an elder age. That's when your embryo quality or progression will be slightly poorer. Hence, your success will be lower.
Yep.
That's why up till now, when we quote success, is always by age of the mother. Still,
Yeah.
of course, we can personalize. There are certain factors if we discover of either the female or the male that is a poorer prospect, then we will have to tell you, okay, this is your baseline by just age group. But because you have this factor additional, your success may be lower than average.
Wow.
So that's why when we quote you the success, it's not individualized in a way. But if you are the lucky one, it's 100% for you, put it that way. So
Yeah.
in general, IVF, I must say, the whole population, all ages, it actually can only help 30% of couples. It's not for everybody.
Mm.
And you need to understand, if you fail a cycle, before you embark on another one, things will change. Life changes, life priorities. You may
Yeah.
delay things.
Yeah.
And then age will catch up. If you delay too long, all these factors will start coming in.
Yeah.
So it's real that if you wait longer, your fertility chance will also drop with IVF.
Yeah. Yeah.
But I will talk about, cumulative live birth rate later on.
Yeah. So I mean, then we always get often asked the question. So okay, egg quality, obviously matters a lot. Is there anything out there that can help improve egg quality?
So a lot of us will so-called relook at your so-called lifestyle lah. So if you think you are on the so-called high BMI, we would advise you to lose it, because high body fat will drop your response to all our drugs.
Mm-hmm.
Then quality ultimately is affected. Okay, and high fat is actually oxidation process, so it's no good for any cells anyway. And most importantly, if your menses is not even regular, means there is component of weight ratio of fat to body mass. So that's one thing to think about. Then think about any medical factors that you can improve. Okay, if lifestyle has been supported fully. Then I do advocate a little bit of supplements. Of course, basic supplements for fertility will be things like folic acid, because that's for your baby. Okay, that's not for you to get fertile, but it's just if you get pregnant, it is a good to have to prevent deformities.
Yeah.
Vitamin D is very important. It helps implantation.
Okay.
95% of Singaporeans are low. That's why I advocate just take it in low doses. You can never overdose.
What dosage? What dosage would you recommend?
Okay, if you are meaning daily intake, you are diligent, minimum 1,000 to 2,000 units of tablets. So it depends what formulation. Actually, vitamin D is best intake via oil droplets, because it's best absorbed. Yes, it's best absorbed via oil. So it depends how lazy or diligent you are. If you're the daily type, you can go for tablets, 1,000 to 2,000 IU. But if you can find oil droplet, actually, they do not need to be such high doses, because you absorb way better.
Yeah.
And personally, I take cholecalciferol, is D-Cure in trade name. It's very high dose. It's 25,000 units.
Wow.
So, yes. So, I take it every 2 to 3 weeks for my own replacement.
Once every 2 to 3 weeks?
Yes. So, it's a high dose oil capsule.
And can you buy it anywhere, or do you have to see somebody?
It needs a prescription in Singapore because it's very high dose. But it's quite easily obtainable otherwise.
Wow, okay.
Yeah, so that's definitely necessary for implantation. No harm to have, because we hate the sun, right, in Singapore.
Yes.
And of course, basic supplements of so-called antioxidant nature is in general welcome, meaning it won't harm us females. Things like coenzyme Q10 is a good antioxidant. There are some papers that prove that it may potentially improve eggs.
Okay.
I don't look at it just improving eggs. It's just delaying aging is good, because delaying cell so-called aging, right?
Yes.
So it's good to have IVF patients. I encourage high dose, meaning easily 2 to 300 milligrams a day. No
Mhm.
harm up to 600 milligrams. If you want to throw in a bit of vitamin E, go ahead.
Okay.
Patients who with polycystic ovaries, I do encourage a bit of inositol. I feel that it helps the hormonal regulation internally.
Yep.
And enhance the response of these ovaries that are a little bit dormant.
Mhm.
So polycystic ovaries is they have the ovaries, right? They have
Yeah.
the numbers. I mean, it's just the quality and the responsiveness of the ovaries, literally.
Yeah.
But for men, in terms of supplement, usually if you go to any pharmacy and look for what we call health supplement for men's sperms, it comes in a series that is quite predictable. Means L-carnitine, zinc, selenium, low dose CoQ10. I just want to warn that CoQ10 in men should not be high dose. Otherwise, it has a reverse effect.
Oh.
So yes, so it should only be maximum 100 to 150. So if you look at the men's one, they do not go very high dose actually. But it is good to have, especially if the profile is the smoking type, or
Yeah.
you have to socialize late night all the time due to work. You're never getting enough rest. I think no harm literally.
Mhm. Okay.
Yeah. So this is the more natural way.
Yes.
But if we are already embarking on IVF cycle, we always relook what can we change differently from the so-called previous cycle that has failed. Is there any additives that can potentially help, push our so-called next eggs to perform better?
Yeah.
So there are certain drugs that in our world that we are still debating sometimes in big conferences. So the main derivator to grow eggs is actually called FSH injections, the hormone called FSH. But if you add a little bit of LH, which we believe some aging eggs require LH to boost the performance and the growth, that's when we will add on different brand drugs with this component. Occasionally, you will hear some doctors using growth hormone. The evidence has been, plus minus. I would say very solid evidence, but there's no harm. Occasionally, it's a little bit like a cocktail, but there's no harm for certain patients to use prolonged cycle to boost quality. You are not talking about miracles like creating 10 eggs, plus 10 eggs, not like that. It's
Yeah.
just that each egg is going to be precious at that point in time. Hence, you want to try to improve.
Yeah.
So all these are called add-on therapies. But most of us are quite conscious that if you think you are a normal responder, we should start with the basic. If the basic works, that's all. Otherwise, that's when we will add on a little bit and hope that things will improve moving forward.
Yes. Okay. Just a question to ask about supplements again. Okay. Sometimes you get the question. So when should I stop the supplements? Should I continue taking them until I do my FET, or or until I get pregnant, or what? Is there anything that should be stopped or can continue?
I continue all the way until pregnancy proven or FET. So basically the reason is because we do not know what impact of say CoQ10 has on the embryo or on
Yes.
the pregnancy. So the moment we actively get you pregnant, transfer,
Yes.
maybe you want to consider stopping, or if you know you are UPT positive in a natural pregnancy. But
Okay.
common supplements like folic acid obviously don't stop. Vitamin D, please continue. And if you have just the standard prenatal, just continue. Those are no harm at all.
Okay. And that the common question, should I take for a number of months before I start, or do you think if I should just start now and then it doesn't matter when I do my cycle?
So if you are ready to conceive, so again, whether you have the timeline, how long have you tried? If I feel that it's semi-urgent because your eggs don't permit, especially if you belong to the very very low egg count, we call it premature ovarian insufficient. See, those group you may not want to wait. Concurrent therapy is actually good. But if you're young with good number of eggs, then truly your lifestyle has not been, optimal. You can take, say, 2 or 3 months, optimize yourself, and then come back and embark and start the journey.
Got it. Okay, sounds good. In terms of how many cycles is considered normal before success, or before you start like rethinking things?
Okay, so like I mentioned, IUI is minimum 2 to 3 cycles.
Yes.
Actually, IVF goes along the same line, and that is if you persist, meaning you do not give. Okay. So I was going to come to this topic or concept of cumulative live birth rate.
Yes.
So when I say on average, all ages, we can only afford to help 30% of couple is because there is a variation. Obviously, some will give up. Some truly cannot get pregnant after their maximum cycles. So this is on average. But if say you are a younger patient, anybody less than 35-year-old, I feel minimum to reach what we call a cumulative live birth rate after 3 cycles, you can actually hit an easy number of 60 to 70% for your one baby. So actually, 2 in 3 in this age group is actually a very decent number, because you need to remember that why did you need IVF in the first place? There's probably some issues inherently that is not allowing you to get pregnant, right? Knowing this factor, you cannot be telling me, oh, I just try once and then nothing is happening, I give up and I stop.
Yeah.
Because per cycle at age 35 is only going to give you a success of say 35, maximum 40%. But if you continue trying, as long as you don't take a too large a gap, don't wait until 40 years old or something, every cycle is going to give you that additional success. So hence, if you're 35, easily 60 to 70% of you will get pregnant by the end of 3 cycles.
3 cycles.
If
3
you're
cycles, we're
younger,
talking about 3 transfers or
3
3
pickups.
pickups.
So when
Okay.
I talk about cycles, you're talking about 3 ovarian pickups. Okay?
Yes.
Regardless of age, unless you're telling me you're very, very young, you have a lot of embryos, and that's a different story because that's a different profile, right?
Yeah.
I'm talking of an average. But if you are on the extreme ends, okay, so say you are 42-year-old, I tell you your success per cycle is only at best going to be 8%. Then this is when you have to rethink how many cycles can you afford. Number one, mentally, physically, time. Don't talk about costs in Singapore. But I do have patients who do it, and to so-called reduce mental stress or reduce transfers, they actually do PGTA. Means they accumulate cycles. So every month they're just going to collect eggs, be it 5 to 6 cycles. They get good blastocysts. That's when we'll do a biopsy. And I have still, a few ongoing. Of course, it's not permissible in
Yes.
Singapore. I'm
Yeah.
talking of other countries.
Yeah.
So the question is, how much can you afford? How resilient are you to go on and on about this? Yeah.
So that comes to my question. In terms of embryo banking, all right? So let's say for a lady, let's say not young. So we're past the age of 35, okay? Because we see a lot of that, 37, 38.
Yeah.
You said a cumulative rate, let's say maybe 3 or more, okay?
Yes.
Would you suggest that they just bank, or retrieve, transfer? What's your thoughts on that?
Okay, so I do look at age profile and what is their baseline follicle count or baseline egg reserve. Okay.
Yes.
And at the first consult, if they're due for IVF, that is, I actually do ask what is your family fertility wish. How many babies are we talking about here? Same as social egg freezing, right? I have to ask how many are you looking at? If you tell me 3, then I'm going to be honest with you. At age 37, 38, you need 3 rounds of embryo banking. But if you're telling me, no, I've come a long way. I've not been pregnant ever. One baby is, more than enough. Then if you are this sort of patient, then I advise every round you transfer. Because the moment you get pregnant, it's all good, right? I mean, 95% of pregnancies will go well after an IVF. So there's a lot of natural selection in IVF. The poor ones will self-eliminate anyway. Yeah, so that you don't waste time. Yeah. So it depends on your family wish in terms of, yeah.
That's a good way to get it. And then in terms of, okay, we talked about PGT just now, right? PGT testing.
Yeah.
If that person say, okay, then same thing again to the question, should I, every time I retrieve, let's say I want only one child, should I still do embryo banking and then send all? Is there a number that you need to accumulate before you send for PGT?
So yes, so most PGT centers or IVF centers that does PGT, including the Singapore government ones, actually there is a fixed so-called cost effectiveness to it.
Okay.
So they do by batch processing. Okay. So what I feel is depends on your age group, of course. It goes by what we call chromosomal abnormality rate, right?
Yes.
If you are 35, 50% abnormality, I would say actually 2 to 3 embryos more than enough, right? But if say you are almost 40, you may want a bit more. I would say 4 to 5. But on average, most centers will be minimum 3 to 4 good quality blastocysts. So you are talking about quality because they need to ensure they will survive, even if it's normal, what we call euploid embryo.
Yeah. So we're talking about good quality.
Is 3.
Good quality, what kind of grading are we talking about?
So if you all know this so-called Gardner classification,
Yeah.
I would say minimum a 4 BB and above.
Okay. All right.
Ideally.
Yeah.
Yeah. So anything 3 and under, you have to rethink, you have to reaccumulate, put it that way. Yeah. Because you may fail from the other embryo quality issue. Nothing to do with the genetics.
Yeah.
Yeah.
Okay. So we've got a question from Catherine. So Catherine says, Doctor, I have 7 blastocysts left after my first FET and I ended up with a miscarriage. Would you advise for me to send the balance for PGT?
So questions would be, is this the first round of IVF? If it is, I am going to be honest, a little bit of tender loving care to you. Try again before you consider PGT because you can get pregnant. Of course, I'm hoping that there are some embryos out of these 7 that are of equal grading, meaning your pregnancy chance is good. Miscarriage risk, unfortunately, whether it's IVF or natural, is a baseline risk. It will be there. 5 to 10%, we have to accept. But having 7 good blastocysts, it means that actually her prospect to begin with is a good IVF patient. I think she will get a normal baby at some point. So maybe 1 or 2 more transfers before we consider that. Unless personally you cannot accept the mental stress of a miscarriage, then it is a valid reason.
Got it.
Yeah.
Makes sense. Somebody asked, Tonga asked, does putting 2 embryos in increases the success?
So in layman, yes. The idea is you hit the success faster if you're meant to get pregnant from that batch of embryos. So I give you an example. If the previous patient still have 7 blastocysts, right?
Yes.
If you're meant to get pregnant, 2 babies out of that 7, I put 7 at one go versus I do it 1 by 1 for 7 months. The end outcome is the same. You only get 2 babies. Okay? Make sense?
Yes.
The worry is multiple pregnancies. Okay?
Yeah.
You put 2, you can get 2, but 1 can still split, you get 3 or 4. So that is something we cannot control, the splitting of embryos. That's why all over the world, most first world countries only advocate 1 at most 2 embryos because that's all we can afford in terms of multiple pregnancy.
Yeah.
There are circumstances that I will allow 2 blastocysts. This is also Singapore law. If you have failed many times, means inherently there are problems with your embryos, okay? Or some form of unexplained causes. Or we think that your grading of the blastocyst is not so good. Then I think it makes sense to hit your pregnancy, or rather what we call shorten the time to pregnancy. So rather than 1 times 7 months, if I can put 2 for 3 times, it shortens it 3 months only. That sort of concept. But first 2 rounds, if your blastocyst, we usually use the best blastocyst first, right? In terms of grade. If we think the odds are very good, usually we will advise only 1 the first round. Yeah.
Got it. And Namiko says, I just had a chemical pregnancy. I do not have any embryos left. I'm 39 this year. Would you advise for me to start egg retrieval after my next menses, or should I wait 3 months to improve on my egg quality? So she's 39.
Honestly, turning 40, I wouldn't wait too long. So 1 cycle downtime, 2nd cycle, I would embark on the next, IVF already. Unless for whatever personal reason that you feel she need to boost things. Yeah, I'm very sure during the first cycle, she would have fulfilled certain criteria, meaning she would have done her best in, say, supplementation and all this would not have miraculously disappeared, right? The effects. So I wouldn't wait at age 39, honestly. Yeah,
and if she hasn't started her supplements or anything, she can also start now, right? And
of course. Yes.
Got it. Wow. Okay. There's a hi, Dr. Jessie Trixie. I think she is your patient. So we had a successful live birth with you. We were left with 3 blasts after you left KKH, and unfortunately resulted in 2 chemical and 1 failed. Any advice that what we should do before our next fresh cycle?
So I have to reiterate, restart your whole journey process again, reevaluate your health, start all your supplements, start your goodies, start your exercise regularly. As long as you're a healthy lifestyle, I think don't wait too long, go and start your 2nd cycle. Because if you can get pregnant naturally, you would have. Because I routinely advise my patient, please continue trying naturally while
Yep.
awaiting IVF or the next pregnancy. Because I've got a few, even though very what we call poor responders and all, who get pregnant naturally.
You never know. You really never know.
Never know. Yes, exactly. So there is a what we call intervariable egg pool every month. That's why you have a variability, you see. Yeah.
Got it. So, okay, we're going to go into recurrent failure now. But before we go into that, somebody asked, does doing an endo scratch before a FET increase success rates?
So again, it's one of those add-on therapies where the evidence is not very strong.
Mhm.
So they've tried a lot of trials, but certain groups say it does, certain groups doesn't. For me, it's about whether it's harmful to you. So I do offer my patients after say 3 failures in implantation, especially if they're good embryos, means good quality blastocysts. I do offer because it's relatively risk-free. The only risk is a little bit of pain during the procedure. So I tell them to just take stronger painkillers or 2 Panadol 2 hours prior. It's just a small little catheter going inside the womb and 1 or 2 rounds of so-called quick scratching.
Yes.
No harm. I won't say I see a sudden improvement, but you do improve, you will say, hey, that's a good treatment for me, right? But at least you're trying your best in understanding what are the add-on therapies, why did all this come. So it's not wrong to think that, hey, actually the concept works.
Yeah.
Same as how now we do laser, right? We injure our face a little bit, hoping for good cells to appear and we look better. So in the womb, it's the same concept. I injure my lining a bit. I'm hoping for good cells to come in and repair that defect, and this will aid the implantation.
Yeah. And your mind also kind of tells you, hey, I tried something new, right? Maybe it's better this time.
Correct. So it's the same as things like what we call ERA test or receptivity window, right? So we talk about fertile window. Fertile window is because when a natural ovulation happens, you have a natural rise on progesterone, and then you have this window that you cannot miss because once the progesterone is too high, it's no longer receptive. So same concept as this, because when we do our IVF, we will always lose the natural window.
Yes.
So that's the reason why a lot of clinicians will advise what we call frozen transfers. Freeze because this lining is no good. I won't say 100% everybody don't fulfill. I've got quite a few of fresh transfer, but I will look at the stimulation regime. So this concept is if you have repeated failure, and we think that only factor now is the endometrium, the lining. Okay, it's not about the thickness. You can grow the thickness, but it's about the window. Are we missing the window no matter what we are doing? Again, the evidence is not extremely strong. It is relatively expensive because we don't do it in-house, means it's not in Singapore. It's always a send-out test. No harm, as in, again, like you said, we have tried our best. Let's try something different. On and off, we do get surprises, meaning you're supposed to transfer on a earlier by 1 day endometrium. But it's rare. I'm going to be honest, rare. Most of the time, it fits the same timing that we routinely do it for.
Got it. And then in terms of ERA, so this is always a question I get. What is the downtime? So, okay, we're desperate to transfer. So if I do an ERA, what am I looking at? When is the next transfer?
Minimum 1 month. So that 1 month cycle, you cannot. Okay. Now the good thing is they have embarked on what we call a blood test only. You don't need to scratch. Yeah. You don't need to send the endometrium per se. Last time it's painful, right? You scratch twice. Scratch twice and send the result and then look under a microscope and whatever. Now it's via a blood test. They are looking for molecular changes. So it's much easier now. Last time we will say definitely 1 month downtime because you can't even have sex. You can't even try naturally for that month.
Yeah.
But now actually it doesn't really matter. It's just a blood test, but definitely 1 month downtime.
Oh, and that blood test also gets sent overseas as well.
Sent overseas. So the nearest that I know is Taiwan. They run it. So Taiwan not too far. So the time to get back a report should be quite soon. Last time the first ever creation was like either Spain or US, then it takes a very long time to come back. That's why it's a downtime of 2 months. Nowadays within a month.
How about, okay, so there's ERA then, but iGenomics, they have the Emma, Alice and all that kind of stuff, right?
Yeah.
I mean, what's your thoughts on that?
Okay, I personally not use Emma or Alice.
Okay.
I'm not so sure I believe in it. I believe in endometritis. Okay. So it's chronic blood inflammation due to previous events of infection and whatever not. So that one, I just need to do either a hysteroscope or a scratch to send for histology. And I tell my pathologist what to look for. If it's infection, inflammation, obviously antibiotic is the mainstay. And a lot of these patients, if I believe it's about microbiomes, actually a lot of them I actually advise probiotics also. Same for my pregnant patients because of these hormonal changes, they tend to get a lot of vaginal infections all the time,
Yes.
coupling them, right?
Yeah.
So I said, why don't you just take probiotics as a routine? It helps you anyway. So I'm going to be honest, I don't routinely do all this. And
Okay.
the few who ask me from, say, overseas, when they ask me to do it, I have had negative results. That means nothing has turned out positive. So it's a very,
No, it's good to know. It's good to know because it's
it's a very
often
small
question.
section, I must say.
Yeah. How about intralapids?
Yeah. Okay. Again, if it doesn't harm you, no real, so-called say no to it. I won't say no if you are asking me for it, but do I believe it helps? I don't think so if your diet is good enough. So it's just fats, right? High concentration fats.
It's like soya milk like that.
Correct. High concentrated protein fats. You can eat avocado, a little bit of durian here and there. So if you are well nutrition, I don't see why you need it lah. But if it's easy access, you don't mind running the, drip. Okay, so the caveat is most patients who end up with this profile are already what we call poor responders, right?
Yeah.
Or rather low, a bit lower odds lah. So it's when you want to do everything to feel that you have done everything. I think it's fair. But you need to be fair to say that actually I am at the lower end. If I don't succeed, it doesn't mean this treatment was no good for me.
Yeah.
Yeah.
Fair enough.
Because
Okay.
70 to 80% is due to the embryo. I'm going to be very honest.
That's the thing, But I think we're trying just to see what is there. When there's one more thing that, as much as paying money, and a lot of people, it's expensive, but you also have that mindset. If I don't do something different, like nothing is going to change.
Yes,
Unfortunately.
it's true. No, it's true.
Yeah.
And to convince you that actually every cycle, even though I do the same, the outcome can vary because it's all about getting good eggs and getting good sperms at the point in time.
Absolutely. So, okay, we have another question from Rolling Switch. She goes, hi, I have 6 day 5 blastocysts in my first cycle, but none of them implanted, not PGT tested, and I'm 35 years old. I'm starting a second cycle soon. Are there things I can do to improve implantation?
Okay, this one I definitely will do investigations because I feel this one is a little bit in the group of recurrent failure that is of unexplained origin. Because 35-year-old, definitely 1 out of 5 should have implanted, whether it's a biochemical or not. So I think we got to relook at her profile and the husband's profile. Is there anything we can optimize as baseline? Okay. Source from medical diseases. Is there anything underlying? And I would definitely offer her karyotype. Means your own genetic, to see whether you have any what we call underlying what we call
genetic issues or
imbalances lah, put it that way.
Yeah. And karyotyping, maybe just explain what is it? Is it a blood test or?
It's a blood test to so-called type our normal chromosomes. It doesn't tell you the wonders, but the basic chromosomes. Yeah.
Do both parties do it or just one person?
You have to do it as concurrent because it can be the male issue also. And of course, if you are going for PGTA, then maybe it doesn't matter that you don't have to do this karyotype because the treatment is PGTA. But it proves to me that you need the PGTA if we find something abnormal.
So PGTA can also find these genetic issues if there's issues with the embryo?
No, PGTA ends up with a better outcome because this is a treatment for abnormal chromosomes. Yeah. Okay, then you only transfer normal. If you know the whole batch is abnormal, you wouldn't have bothered using them.
Yeah. So, and it saves the heartache and everything as well.
There is a underlying medical problem of the autoimmune nature called the antiphospholipid syndrome. So we do put it together with what we call recurrent miscarriage or recurrent failures. You may want to screen that because that one, the treatment of aspirin together with what we call anticoagulant injection can potentially help you conceive easier. And usually most patients we start the moment they're pregnant, but some we actually start from the time of transfer.
So it's good to know if there's issues, at least you can start figuring out how to solve them beforehand, right?
Yes. Yeah. To avoid miscarriages especially.
Yeah, which is... So, okay, we'll just now go into recurrent failure. We have so many questions. Anyway, I got so many questions coming up as well. So, at what point, do we say that, it's not just bad luck, it's really a recurrent failure? What is constituted by recurrent failure?
So my threshold for a not too old means less than say 38-year-old, 3 good blastocyst transfers. If none of them ever implanted, I feel that is, some form of failure that we have to embark on the next journey of re-evaluation, finding other reasons, whether it's medical, or it's embryo quality, or some form of what we call uterine factor, means the area.
Yeah.
So it goes along to what we mentioned earlier, whether you offer endo scratch, ERA tests, all those extra blood tests before we embark on the next cycle. That is.
Yeah. And then what if it did implant but 3 miscarriages?
The more you should do your karyotyping, or you go straight and do PGTA, because high chance or high odds is due to chromosome abnormality. Of course, at the same time, if you have a time, because you're bound to have one month downtime, put it that way, when you know your result, right? You may want to concurrently screen yourself for things like antiphospholipid syndrome. Ensure you don't have, thyroid disorders, diabetic disorders, because all these are in the same family.
Yeah. So, okay, Jess says, I had a successful FET last year, but unfortunately ended up in a miscarriage at 21 weeks. So sorry. How long should I wait to do another FET, and what should I do to improve my next transfer?
Okay, so 21 weeks miscarriage really depends on the cause. Is it a cervical reason? Is it an infection reason? General recovery for at least what we call a second or third trimester, we would say minimum 3 to 4 months. Because you want this enlarged womb to recover in its what we call vasculature for good vessel supply. It's the same as after giving birth, we always disagree if you get pregnant within the year. You see, you don't have enough recovery for the womb. So we will say minimum 3 to 4 months, because this is just second trimester. And once you get a scan, look at all the vessels, the womb lining, all recover, and mentally you are ready, your acceptance, I think that's when you can embark anytime. Yeah.
Is there anything she can do to prep her body in terms of supplements and everything? Can she start those now, or would you suggest still waiting?
Okay, so I think it's the same patient that I saw. It's due to an infection cause. If it's an infection cause, usually it's immunity. So all patients who are pregnant, the moment they are pregnant, their immune system is lowered than general. My advice is you need to find a way to up your own immune system lah. So regular exercise, take low dose vitamin C if you believe in it, and then obviously sleep well and eat well. If it's due to so-called vaginal infection and that sort of thing, I actually start, regular probiotics. Anything for immunity and immune system will be good. And then while you're prepping all this body, then just plan your FET once you're ready. Yeah.
T. Well said, I did 4 IVFs between the ages of 35, 36, 1 to 2 day 3 embryos each round, no implantation at all. I've done all the supplements and all. Terrible hot flushes for months after the 4th IVF. She's 37 years old now. Do you advise continuing IVF?
Okay, sounds like she's actually a premature ovarian insufficiency patient, means low egg count. Because at age 35, 36, to get only 1 day 3 is not normal. Okay, so you need to know that you are actually at the extreme end of the poorer odds, unfortunately. It's not that I want to dampen your odds, but you also will need to know that I quoted age 35 need an average of 15 eggs to just give you a success of 35 to 40%. So if you are telling me each round you're only getting 1 or 2, to get 15 to hit that mark means you need to go at least 6, 7 rounds, right? So the question is really what can you afford? Can you afford to continue this journey? I personally know of friends who actually, start from age 35, not too old, all the way until 40, 41 before they conceive their first one. So imagine how many cycles is that? Easily 6 to 7. Pickups. When I talk of cycles, I'm talking of pickups, not just transfers. So it's how resilient you are really and how much you want it. So ultimately, majority will get their own offspring. But I also have the other end of patients that feels that all these injections are not doing them well. They make them go mad, whatever reason. It's a tough journey. The egg pickup is painful. And they feel that things shouldn't be forced. I think I respect that. So I do have patients who fail after 1 or 2 cycles, and now they just see me every year for gynae checkups, and they're happy. Some who have reached the extreme end where we will offer them what we call, best, fastest option, either egg donor or adoption, and they are happy also. So for each individual, I think you need to spend time with your specialist, talk to more people and see ultimately what is it you can accept and what is your threshold. For such patients, I actually like to ask them, what is your threshold? Can you set your own targets and limits? Then we go from there. I won't stop you from trying, but you must know your own limit that you can go. Yeah.
Yes. I think it's really important. And if you want to speak to other people who have chosen, a donor egg route, life without a child route, not by choice, or an adoption route, we have WhatsApp groups. We have groups for all of these, and please talk to other ladies. I think you get a better idea when you talk to other people who've been through it.
Exactly. Then they share their, experiences. It's just easier to digest.
Yeah. And to know you're not alone, at the end of the day.
Yes, exactly. Yeah.
So Anne Namiko says she's got high body fat and BMI. Okay, no. As high body fat and BMI produces poor quality eggs, would you advise the patient to lose some body fat first, or would you advise not to wait for a patient who's 39 years old?
Okay, if you are 39 and very low egg reserve, I think I have no choice but to harvest an embryo bank. But if you can afford the time, it is good to concurrently do things. Okay, so 39 is a very tricky age. Okay,
Yes.
I would harvest and bank. At least try one round and see what's your response. Then unless that one round actually yields you very poor success, then different story. You may want to change. Then we have no choice but to wait. But if the numbers are good, let's bank first. Lose your weight for the purpose of pregnancy. Because you want them to implant, you still need a good BMI. It cannot be too high a fat ratio or you will miscarry and lose the pregnancy.
Yeah.
But if you are, say, younger and extreme BMI of, say, above, BMI 42, 45, I've actually got a lot of patients that went for bariatric and do very well. And in fact, now to replace bariatric surgery is the new, medicine, GLP-1s, the injection.
Yeah, that was my next question. What's your thoughts on all these GLP medications?
It's amazing. If they can tolerate the side effects, so I still work a lot with KK Hospital, running what we call the Onco-Fertility Clinic. We have a fair group of high BMI patients, and to achieve their outcome or target as efficiently in a short manner of time, GLP-1 works very well. It's just that we need to set a limit. The moment they start losing weight, that's when we have to intervene quickly. So we actually don't need a washout for too long, maybe 2 to 3 months, and we quickly do our IVF harvest first, see how they maintain their BMI. If they can maintain, I transfer. If they cannot maintain, that's when I continue GLP-1 a while more until it's satisfactory. But the outcome has been very good. In fact, for natural pregnancy also. Wow. The moment they lose about 15%, or 20%, naturally ovulation improves, then they get natural pregnancy. Because this group, we tell them to, prevent pregnancy, but they won't, right?
Yeah. I mean, So, and then for someone who is interested in GLP-1, because we asked, where can they go and find a doctor? Can they come to you? I mean, do you?
They can come to me for assessment, and I guide them whether they're insulin resistant, how much they have lost, so that I give them a clear plan. Yes. I can guide them because I know how to use the drugs and all. Yeah. But I like to collaborate with endocrinologists because a lot of them are also insulin resistant. Yes. So they need to manage the sugar. Yeah. It's not only purely about losing weight, you see. Yes. So I need to know what threshold of the sugar and all. But if they're straightforward about just weight loss, then yeah, definitely I can do it. Yeah.
Got it. Yeah, that's important to know. Okay. Dr. Jessie, just to inquire, multiple miscarriages, karyotyping done, fetus karyotyping done, RPL, panel blood work all done. Nothing is a problem. Is there other things that I can look into?
Honestly, I don't want to use the word luck, but there is a small subset. Truly, you belong to this small subset that is a little bit unfortunate. If you can implant and get past, say, 8 weeks, actually, we are very hopeful. This is when, actually, in the RPL group, we do use a little bit of anecdotal medicine. So, like I said, even though you don't have antiphospholipid, I would probably offer you the same treatment.
Got it.
Because it doesn't cause too much of a harm. But of course, you need to accept the risks of this treatment. It's still continuing daily injections, even though you think that IVF is done, because the anticoagulant comes in the form of subcutaneous injection. And occasionally, I do see success of such group. fully unexplained RPL, then I will offer because embryos are good and she can implant, you see. It's just about holding that pregnancy to last past the 12 weeks already.
Yeah. So that's something maybe you could consider. So many questions. Should we consider collecting more eggs first without FET? Although I've already collected 7 blastocysts. I think it comes back to the question that you said, how many children do you want, right?
Correct. And what age group are you? If you are less than 35, 7 is more than enough usually, right? If you look at it at 50%, hopefully 3 of them will implant. Of course, you have to factor the 5 to 10% of miscarriage rate. So I do offer what we call embryo accumulation or banking, and sometimes even dual SIM for the what we call conversion group. You know, the 37 to 38 that I was telling you, and their egg reserve. It's not the best, it's not the worst. Say example, first round harvest 5 eggs, 1 blastocyst. 1 blastocyst, I'm going to be honest, success rate at most 35-40%. That's when I tell them, even if you succeed with this, it's going to downtime you by 1 year. Because you 9 months to 10 months to carry this. And then if you want to breastfeed for another 6 months, it's 1.5 years of your life.
Yes.
You are probably not going to get your second one. So that's the group that I discussed with them. If you want to guarantee, I think you should immediately go for a second round. Just bang this first. So I do have 1 or 2 of these such patients. So I'm just waiting for them to come back. So this dual SIM works. Usually the egg difference is plus minus of 3. That's what my experience is. So first round 5, the next round 8. Then if you can get 3 to 4 good blastocysts, I think that's sufficient for her.
So you've seen good results with those SIMs,
Yeah. I do. It's whether this profile can afford the time because it's 2 pickups in 1 month, right?
In 1 month,
And then it feels like you never stop injecting.
But I mean, at the end of the day, if you can get 2 pickups and you can get as many embryos in 1 month, isn't that better at the end of the day?
It's true. So it depends on your profile really. Some patients truly just take 2 months off. I need to do my IVF now. Then okay.
Okay, let's see. All right. Egg count not low. Each round 10 to 11. All right. AMH also not low, but embryos are always 1 to 2 each round. That means I guess the fertilized embryos are only 1 to 2 due to egg size imbalance during stimulation. So would she probably do better with a dual stims?
No. So this is called age synchrony. Embryo age synchrony is not about dual SIM. It's not about shortening the time to egg collection. It's about how to synchronize your follicles when you're starting your stimulation. So this kind, there are some methods to go about. One option is to convert your usual short cycle into what we call a long cycle. That's the old traditional method. Long cycle will synchronize your eggs better. That's why you tend to get more eggs. But
so it won't be a situation where the front ones grow too big and the small ones too small, but you can
won't get such. Correct. You get an average number, but it's not friendly because you'll be like injecting 1 whole month. Basically, before your menses start, you have to start the injections, what we call the blocker replacement. GnRH agonist. Or the other option is you do what we call pre-treatment. Pre-treatment means you take some pills. A lot of us use progesterone. It can also be estrogen. 10 to 12 days prior to the expected menses to suppress your eggs. Then when your menses come, we just wash off for about 5 days and then only start stimulation. This is when we see better cohort of symmetrical growth.
Nice. I think that's something that you could consider, T-Well, and to see whether it can work for you. All right. Let me see. Wow. Okay. I'm trying to see where we are for time and everything. Okay. We're still good, right? When patients are told, okay, embryos are not good, poor quality, right? We obviously understand what that means and everything, but is there any way to see, was it because of the egg? Was it because of the sperm or anything? Some people say, if it's day 3, it doesn't grow well, then maybe the sperm. What's your point on that?
Okay, so sometimes there are very obvious factors. Okay, I'll give you an example. If it's due to the sperm, what we call very severe oats, means the sperm sample only tells me I have 5 moving sperm. Those are very bad. We know that is due to sperm factor. Okay, but egg usually, the embryologist will also give you an idea. When we harvest eggs, we denude them before what we call fertilization process. We actually capture the look at all times. So if there's some imperfections, meaning not by the biology book look, that's when we call them quality issues or in general egg factor. So there are quite a few components to it. size of the egg, the color, the darkness, the thickness of the zona, how much nucleation form. But in general, we do have a better idea for the unexplained group when you do IVF. So I always tell my patients, yes, sometimes I don't know the reason. You do IVF, it gives you an outcome, but we do discover a bit more during the IVF because the embryologist can give me more answers. So these are the group that I will speak to the embryologist. Hey, what do you think? What is the reason? Then she will tell me her honest opinion, what she feels about the eggs. Because you need to understand, they look at thousands, right? Every day they are looking. If you have 5 patients times 10 eggs, you're talking about 50 eggs or millions of sperms. So they sort of have an idea how poor the quality or how good it is. And then nowadays we do a lot of what we call time-lapse monitoring of your embryos, how they divide, how they grow, right? And all the nucleus, how many nucleus per embryo, that sort of thing. It gives us an idea what's the problem. So poor fertilization, if the sperms are poor, then it's sperm factor. But if they cannot fertilize and your eggs actually show a lot of imperfectness or lies during the injection, the embryologist tell me, hey, the egg just break down. That's definitely an egg quality issue.
Yes.
Okay. Then if you have a normal fertilization that gives you a good yield of day 3 embryos, but they cannot blastulate. So blastulation is about 50% of your day 3. Yeah? If you have less than 50%, so only 10%, 20%, high chance is egg factor, because for them to convert from day 3 to blast, actually usually is the powerhouse, the generator. So it's the performance of the egg. So that's when you have to work harder on the female. So in a nutshell, females are more precious.
We are more important at the end of the day.
Yes, we are.
So just now you mentioned that, the embryologist obviously can see a lot from,
Yes.
the egg and everything. So what happens if somebody wants to come to you, okay, from another center and everything? Is there anything they can bring to you? Because, like an embryology report, will that tell you? Or pictures or videos, or what can they bring?
Yes, so I definitely want what we call the IVF summary. All IVF patients deserve to have their own IVF summary. It means it actually tells them the date of egg collection, how many collected, how many mature, how many fertilized, is this ICSI, is this natural IVF? And obviously best is because of time-lapse technology, we actually have photos nowadays. That tells me what sort of pre-BB. Of course, the 5AA or 6AA, I don't really care, right? Because they are top-notch, right?
Yes.
It's the mediocre that I want to know a little bit more, how to decipher, should you go for another cycle versus let's try double embryo transfer, use these 2 up, that sort of thing. So it's the moderate ones that I want, so that the photo actually helps me a little bit more. But I can understand that a lot of patients don't have the photo, it's fine, but at least give me a summary so that I know whether it's a normal stimulation and that the whole cycle has gone through normally.
Yeah. So I know for a lot of patients that obviously if they come from a private center, then the summary is easy to take. But let's say if they come from, public, how do they take it? You probably know better how they go and get the summary back.
Okay, so actually, but this is KK practice lah. But in KK, actually, all patients who complete the cycle should meet the embryologist, because the embryologist will give them a breakdown. If they actually bother to turn up, the embryologist will spend time with them explaining the cycle, and they have a summary. But obviously, it's not in photos because at that point we don't have time lapse, right? But we have breakdown to explain what they think because they look at the embryos, right? So there is a summary. It's just that they don't come back.
I didn't even know KK offers that. So
we have a summary. If you actually come back, we actually suspend time.
So wait, when do they come back? So after a failure, because they were saying
after finishing a cycle, actually, if they don't do a transfer, they don't come back. That's a problem, right? That's a frozen transfer. They don't come back until they do a transfer, right?
Yeah.
So then it's a bit late, but they still actually get the IVF summary. But if you bother to come back at the end of the day 6 freezing, actually they will spend time with you. Because
we gotta tell our group of ladies this.
Yes, if you want to know better, come back, make an appointment, ask the nurse when is a good time. Usually they are freer in the afternoons, so come back in the afternoons. Okay, I want to have my IVF summary. Can I speak to the embryologist?
So we're talking about in a FET, basically in a FET after day 6 and everything, so you can make an appointment and you come back and the embryologist will talk to you.
Yes, or if you don't do your FET, okay, fresh cycle, you obviously may not know your full outcome because day 5 you transfer, right? If you still have ongoing embryos, day 6 you won't know because you don't come back. That's the problem. But if you want to know, you can come back. Say day 7, day 8 onwards, lah. So So speak to the nurses. They are actually quite nice people. Choose an afternoon to come back.
See, we don't know. Me and Angelia, we've been here for so long, but we don't even know this. But how about, let's say for a lady who, okay, they don't think about this now, okay? So now they failed. I want to leave. Unfortunately, I've decided that I want to leave KKH now and I want to go to private center, okay? How do they get the report?
Just email KKIVF. All patients have the email address. Don't tell me you don't. And you also have the hotline number. Tell them, I did my IVF this year, this date, whatever. Can I please have my IVF summary? It belongs to them. It's just that it's in the folder. But if you don't come back, we cannot just, mail it to you because it's not fair. Usually, we nephrologists want to meet them. It's just that we don't come back. So, yes, you
see, this is so useful. Okay.
Yeah, you can get it.
Okay. And then for NUH, this one I know because I did mine at NUH is that you need to go to the center and then you pay don't know how much and then they will prepare it all and then when it's ready they'll call you and then you go and collect.
That is if you want the whole cycle regime. Means you want.
Is that important or is that not important?
Okay, okay, it is important to a certain degree so that I know what to start you and what not to start you. So I like to know, how have you responded? If I know roughly what drug, you know what drug, this dose is sufficient, okay, then done deal, I don't need more. But some patients are a bit more complex, right? Then it will be ideal to have the information. Or at least maybe you should disseminate your app and your booklet lah. Every patient should take charge of their own stimulation cycle. We shouldn't not know what drug you are using when you are doing these daily injections, right? So you can keep note and come and tell me this information. Then I'm at liberty. I do not need you to pay for your medical report.
So seriously, for those who are undergoing, please just bring a notebook with you or download an app or whatever and just record down your stimulations, your drugs.
Yeah. It will they don't stop you from copying your numbers. It's fine. You can copy his numbers.
We feel bad, at that point. And when we start off, we really just don't know anything. And so we just presume first round we're gonna succeed already. Why do we need to, record this down and then little do we know how many years later?
We actually like patients to take charge of your own, you should know about your own health, right? Whether you succeed or you don't succeed, you should know what has gone into you. How have you responded? Are you behaving normally?
Yes. 100%. So Rolling Sweet says, thank you, doctor, on explaining the karyotyping earlier. Is it true that every batch of egg retrieval is different? Why is it so since I'm older, this cycle, why is that so? Since I'm older, this round compared to the previous round. Okay, don't quite understand that, but I think maybe you can answer the question.
I think I understand. Okay,
got it.
So basically, we call it inter-month variability, same as the egg numbers. So every month when we scan you, you have a baseline number. So I tell you, okay, this month 5 on this side, 5 on that side. I'm hoping for all 10 to grow. But the next month when you come back, you can have a different number. Maybe 5 on one side, but 7 on one side. So this is called the month variability. Same concept as why karyotype will be different, because it's a different batch of eggs altogether. So our eggs, naturally, every month is undergoing death, cell death, we call it. And in your younger years, 50 to 200 eggs are dying off easily, okay? Only one will be selected to grow and ovulate. That's why most of the pregnancies are one. If you get a long tie, you are just lucky that you got 2, okay? But otherwise, it's one out of the hundreds that are dying off. So this batch you have harvested, if you don't harvest them, anyway, they're going to die off without you knowing, okay? So next month, you come back again for another harvest. It's a different pool of eggs. So we are hoping that with this variation, every month, we are hoping that you have some good eggs in there. That's the concept of IVF. IVF is a bit like probability game, unfortunately. You need to know you are not conceiving naturally. There may be a problem. So what I want is numbers. If I can grow everything, I'm hoping for 1 or 2 to be normal there to give you that success that you are desiring. So that's why there is that difference.
So, if a lady basically, she has a round and then she has second round and then the second round doesn't do as well, she shouldn't feel so demoralized, right? The next round may be better?
Exactly. The next round may be better or rather a different pool, hence giving you that chance. So same concept as what I said, the cumulative live birth. So 10 of you go in. Let's say I tell you only 40% success. First group, 4 of you will get pregnant. But the remaining 6, if you continue going on, maybe another 2 or 3 will get pregnant, right? And then the remaining 3 or 4 go on, another 1 or 2 will get pregnant. So ultimately, the cumulative success helps if you are persistent enough. Yeah.
So that's what you need to do. Sorry, Catherine, I missed your messages now. But okay, Doctor, day 6 blastocyst success rate compared to a day 5.
Okay, if the grading is the same, I equate them as same success. Yeah. So you need to understand sometimes they are a little bit late bloomers just by the fact that you harvest your eggs at different hour. You do your fertilization at different hour. We can't calculate to the actual hour, right? That's why they become good blastocysts only on day 6. Yeah. So they are not inferior. Yeah.
And I think some people get confused. They think that 5, the number in front is the day. It's not, right? So, you know, like a 5AA and a 6AA, they think it's because 5,
No. Day 5 means the blastocyst was formed on the day 5, good enough to freeze and use. Day 6 is it only converted to the good blastocyst on day 6.
Yeah. So I think, we need to clarify that because some people think A5AA is a day 5 AA and a day 6 AA.
No.
Correct.
Each of them got their own grading. Yeah.
So, okay, we are almost there, but we are, actually we have so many questions, but maybe we'll do a part 2, but
Yes,
okay,
sure.
For men who have bad sperm, poor sperm quality, you know, anything that can be done, just now you mentioned supplements and everything, but anything else that can be done?
So what I advise the patient, it will be the same as for the husband. So both of them should come together so that they listen to me nag at them together. So essentially, I will tell them, okay, I'm telling you to exercise to lose your fat. It's same for your husband. Let's go together. Both of you find an activity that you enjoy and go and work it off. So again, the sperm quality is not about losing weight only. Losing weight for men is important. Actually, they do produce better quality. But the act of moving, not too sedentary, actually helps the quality. So that healthy lifestyle, sleep well, eat well, reduce stress, cut smoking if you can. Okay. Reduce social activities if you can. I mean, I'm talking extreme ones. I'm not talking of those that is leisure. So same as alcohol for the women who are trying IVF. I don't stop them, you know, one glass of wine every 1 week or a few days is fine. Okay. But the moment you're pregnant, obviously you have to stop that. And then men, of course, on top of the supplements, it has to be taken daily. A normal cycle of sperm production is about 3 months, unfortunately. So you want such intervention, you need to take 3 months of all this.
Okay.
Yeah. And what is important and a lot of IVF patients probably don't know is I actually like them to masturbate or have sex very regularly when they're embarking on such journey.
How regular is regular?
Every 3 days if you can. Yeah. So all my IUI, IVF, the moment the wife starts stimulation, I will tell the husband, I need you to clear your sperms every 3 to 4 days. You can have sex in the early part. It's just later part because the eggs become too big. You get very bloated, right? That's when you avoid sex. Yeah. But otherwise, they should clear. And the new age thinking is actually we don't like prolonged keeping of sperm. So whether it's IUI, IVF, it's okay to clear your sperm just 2 days prior to the supposed day.
So previously it was longer than that, right?
Yes. Last time we always say, we need to keep because the numbers drop, right? Actually, nowadays, if you want good quality, you need to clear. So more regeneration, more fresh sperms. Yeah.
Got it. Our Dr. Tatsin would like to ask, would you prefer a day 5 BB or a day 6 AA?
Okay, normally I don't argue with my embryologists. I love all my embryologists. They have been good to me. The books still tell us normal progression should be utilized all the day 5 first. Unless that day 5 is truly very poor. My definition is poor is less than 4 BB lah, usually. Okay. Otherwise, because by normality, it is, textbook to advise the normal, let's transfer day 5 first.
Yeah.
But I think now with the advent of time lapse, I feel that it helps. It helps shorten the time to pregnancy to choose embryos. So my private embryologists are actually quite good at going back and looking from fertilization stage, what abnormalities along the way or what normal progression, and I let them decide. So they will tell me if they did not choose the day 5.
Interesting. So usually the choice lies with the embryologist then?
Most of the time, yes.
And so it's quite important.
Unless I discuss with the patient for whatever reason, say she wants two, but she wants the best and the not so good together to use it up. That this kind of story then is a very didactic thing lah. But otherwise, I leave it to my embryologist because they know the embryos better than me, honestly speaking.
Yes, yeah. I mean, yeah, that's their speciality in that sense.
Yes.
Do the patients get much access to the embryologist? So just now you mentioned KKH, they actually can talk, but in private, like where you are and everything, how much access? Because people often think that, the embryologist is behind that glass. I never see the embryologist and everything, but what's
actually the few experiences I've had. So I obviously practice a lot in Gen Prime, and then before this I practiced a lot in Mount Elizabeth, even Alpha, and where else? Let me see, Thompson.
Yes.
Okay. My honest opinion, because I practice so much or more in Gen Prime and Mount Elizabeth, I feel the embryologists there have been great. Meaning they spend a lot of time. They will they actually ask the patient, do you want a phone call update or you want a text? Because sometimes, just
So this is for the fertilization update, right?
Yes, the fertilization day-to-day can be just a text, right? Because it's easier to read. Oh, I have 15 eggs, how many fertilized? It's easier to read. But at the end of it, usually they get a phone call. Okay, if they cannot come lah. If they are there for fresh transfer, then obviously it's face-to-face, right?
Yes.
Otherwise, they actually get a phone call. So I think that is quite easy access. So far, Mount Elizabeth Lighting has been very friendly. Then Lin and Jeff Prime has been very friendly. Yeah.
I think it's good to know because I think a lot of patients feel that I also cannot call up, it's not nice for me to call up to ask and this and that. So I think it's good for them to know that actually, when you are with a center, you can ask, can I talk to the embryologist? They're very nice, I think, to give you an update and tell you what things are like.
Because they do understand that you are very concerned about such things, right? It's not wrong, just ask. I'm sure they will want to entertain you. It's just that you must give them time lah. Because morning is always the peak hour. So same as me, I will always do our procedures in the morning because it takes time to, denude eggs. By the time you do fertilization, it's 3-4 hours later. So you don't want to start all these things in the afternoon. So afternoon is when they have a bit more time to speak to you.
Yeah, I think this is part of taking charge of your journey as your sector as well. Yeah, knowing that you can do that. Oh, okay, let me see. When do you decide? Okay, we're going to ask one more question and then I think that we will leave the rest for our next live. Okay. Sure. But I think this is an important one. When do you decide, when a patient comes to you that it's time, or even like a patient that you've already seen and done but hasn't really gone that well, but when do you decide that it's time to change protocols or try a different approach?
Okay, so we always study together. I always get their opinion. What do they think of the previous drugs that I've prescribed? Okay, any side effects? What do they not like about it? Okay, and then I restudy the stimulation cycle, meaning the response. Did I get the response as what I targeted or expected?
Okay.
If I did, honestly speaking, there's not much change needed. It's just about another batch of eggs. Hopefully, we get a better batch, put it that way, right? But otherwise, that's when we will think about, okay, if there's asynchrony, like I've mentioned, I may employ what we call long-term regulation or do a little bit of pre-treatment. But if it's purely quality issue, then I have to lay the cards. Come on. The drugs, in terms of dosage, is not the problem because there's only so many eggs I can derive from you. So maximum dose is maximum dose. I can, I can let you waste more money, but that's not going to work. So that's when you want to think about other add-ons, like what we call the LH group or what we call a little bit of growth hormone. So I feel growth hormone needs to be utilized a bit prolonged period. Means before your cycle start, you should employ at least 2 to 4 weeks worth, but it's painful, meaning you are doing injections on yourself for more than 6 weeks for that one cycle. Even though it's very small dose, not supposed to have very high side effects. So this type of patients, I do it very selectively. I'm going to be very honest. Yeah. And concurrently, of course, all the goodies or supplements and whatever do not stop. Yeah.
No, it's good to know, at the end of the day that there are options. I think that when you go through IVF and you fail, you are often, I mean, when we talk to girls, they're often very lost. They really feel that whatever I've tried, that's it. There's nothing I can do. And then that's it. That's the end of my journey. So it's good to speak to somebody that can give you options and can kind of tell you and kind of reassure you that even if you're not going to change something, that's the reason why. I think the trust that you have to have with your doctor is crazy, because you're really putting everything into this doctor's hands, and finding a good doctor is there are so many good doctors out. You know, I think Dr. Jessie, honestly, so many doctors that I've spoken to, I really like Dr. Jessie because I feel that down to earth is one thing, but I think that everything that she suggests really does make sense.
Thank you. So I echo what we said from the beginning. Second opinions are good in two manners. One, it gives you the fresh opinion on things that maybe the previous consult has not addressed because time factor or whatever. But it also echoes that if this new doctor agrees with the plan, you are on the right track, essentially. Yeah.
I definitely agree. So, sorry. So thank you so much for sharing so openly today. I mean, we're definitely going to have a next session because we have so many questions and I see more coming in as well. So I'll record everything. We will have a next session soon. But for anybody that's watching, you know, if you have more questions, send them across and we will make sure that they get asked the next time round. And honestly, if you feel that you've done everything and there's still things that you don't quite understand, I think that Dr. Jessie, or, you know, any second opinion as Dr. Jessie, is important to just go and ask. So Dr. Jessie, where are you located? Just let everybody know, in case they want to find you, where can they go?
So you can find me either at Gen Prime IVF Center. Just go and Google Gen Prime IVF, it will appear, the Singapore branch.
Yes.
Don't go to Philippines or something. And my own clinics are actually SEO plus G practice. I've got quite a few clinics around. But yeah, just Google my name and SEOG practice.
Yeah, so Dr. Jessie, Jessie Phoon, Phoon.
Yes.
Thank you, Dr. Jessie, and thank you, everybody.
Thank you very much.
And thank you for asking so many questions, you know, so we will speak to you really, really, really soon. All right?
Thank you, everybody.
Thank you. Good night.
Bye.
Go rest. Bye-bye.
Bye.